the second day. The topic for the afternoon session would be restorative dentistry. There would be 3 lectures on the restorative dentistry by Dr. Neelesh, Rathi, Dr. Priya Subramaniam, and Dr. Subbalekshmi. The session will be moderated by Dr. I.K. Pandit sir and Dr. Nagarathna C. ma'am. To begin with, I would like to introduce the moderator for the session, Dr. I.K. Pandit sir. Sir, thank you so much for joining us from London today. A very good morning to you, sir.
Very good morning to all of you. It is always my privilege because Dr. Madhu had told me much
Sir,
in
you're on
advance that.
mute.
No, it is all right. It is okay from my side.
So, Dr. I.K. Pandit sir started as the youngest dean and principal and director at the DAV Centenary Dental College, Yamunanagar, Haryana. Sir did his masters in 1990 from the prestigious King George's Medical College, Lucknow, Uttar Pradesh. Sir was the past IDA president for the state of Haryana, founder secretary, IDA Yamunanagar branch, and a product endorsement committee member and a state CC member. Sir was the vice president, Dental Council of India. Sir was the past president and secretary general, ISPPD. Sir was the patron and governing body member, South Asian Association of Pediatric and Preventive Dentistry. Sir has academic teaching and clinical experience for more than 35 years in the specialty of pediatric dentistry at King George Medical College, Faculty of Dentistry, KMC Manipal, and DAV Centenary Dental College. Sir is the editorial board member and reviewer in more than 10 national and international PubMed Index journals. Sir is a fellow, International College of Dentistry, fellow Perry Fouchard Academy International, and also at the Academy of Higher Education, Manipal. Sir was a member IDA, ISPPD, AAPD, ISDT, AAED, and also IADR and ISDR. Sir has organized more than 20,000 camps for the downtrodden regarding motivation, teaching, and treatment given at their doorsteps in far-flung areas of Yamunanagar, Haryana. Sir worked as the frontline worker during the COVID pandemic and made people convinced to get vaccinated. Sir has conducted more than 100 camps where with the help of the local administration where thousands of people were vaccinated, including children above 18 years and senior citizens at their doorsteps or nearer to their easy reach. Sir has actively involved in more than 6 research products with international collaborations. A warm welcome to you, sir, on behalf of the organizing committee of Virtual PediaRare 6. Thank you so much for joining us, sir.
Thank you very much for introducing such a long introduction. Because when you become
now,
old,
I would like to introduce the second moderator for the session, Dr. Nagarathna C. ma'am. Thank you so much, ma'am, for joining us. Dr. Nagarathna C is presently working as a professor at the Rajarajeshwari Dental College and Hospital, Bengaluru. Ma'am has completed PDS and MDS from Government Dental College and Research Center, Bengaluru. Ma'am holds a PG diploma in child counseling and also a certificate in special healthcare dentistry. Ma'am has served and contributed to pediatric dental education through various academic and administrative activities. Ma'am has achieved the Distinguished Women Award from the ISPPD. Thank you so much for joining us, ma'am. Now, I would like to ask Dr. I.K. Pandit sir to introduce the first speaker for the afternoon session, Dr. Neelesh Rathi sir.
Okay, it is my proud privilege to introduce young dynamic PhD fellow, Dr. Neelesh Rathi.
Pandit sir, please unmute.
He has done BDS in 2004. Hello? Hello?
Yes, sir, we can hear.
Sir, you are audible. Please go ahead.
No, from my side is okay. I can hear all of you.
Yes. Audible.
Is it okay now? Hello?
Yes, sir.
Yes, okay, sir.
Okay. I am introducing Dr. Neelesh Rathi, a young PhD scholar from our specialty, who has done BDS in 2004 from Sharad Pawar Dental College, Wardha, and MDS from Kotiwal Dental College Research Center, Moradabad in 2009. He has done PhD on the elemental dentistry in 2017 and fellowship in pediatric orthodontics in 2019. And Datta Mega Institute of Medical Sciences, he passed out. In 2023, he has received big BIRAC startup grant to take his research on dental materials to the next stage. He has a number of design patents and copyrights in his name. I recently had a chance to meet with him, and he is bubbling with so much of advanced research and so much of information he has in his mind. I think he is a great credit to the specialty, and we have to utilize his expertise. He's expert in laser and ardent user of implant in pediatric dentistry. He has designed exclusive pediatric rotary files to improve his efficacy, includes efficacy and acceptability of pulp therapy in children. And I welcome him to this afternoon session of PediaRare, and over to him.
Thank you very much, sir.
Thank you, sir. Now I request Mr. Dev to display the presentation.
Good afternoon, respected Chairperson, Dr. I.K. Pandit sir, and Dr. Nagarathna ma'am, and my dear colleagues. Warm greetings from the Dr. D.Y. Patil Dental College. Myself, Dr. Neelesh Rathi, and I'm going to discuss today on an important topic, biomimetic materials in pediatric dentistry. This topic is gaining momentum in recent times because of its requirement for doing a stable restoration. These are the probable questions that can be asked from this topic in the examination. What is biomimetic? Biomimetic is nothing but replacing the damaged part with the original or original-like tissue. Imagine a car which is punctured and it is being replaced by a wooden wheel. This wooden wheel looks similar, but it is not going to suffice the purpose of the original wheel prepared out of rubber and the iron. Similarly, this principle is applicable to the natural tissues also. So biomimetic is defined as a study of formation, structure, or function of biologically produced substances and materials, and biological mechanism and processes, especially for the purposes of synthesizing similar products by artificial mechanism which mimics the natural ones. So this word is derived after joining the two words, that is bios means life and mimeticos, which means imitative. The schema of biomimetic dentistry is given by Lamia Singh et al., in which they have divided into two categories, that is biomimetics in restorative dentistry and biomimetics for dentine pulp complex. The biomimetics in restorative dentistry is divided into two categories, that is restorative treatment approaches and restorative materials. The biomimetics in regenerative dentistry is divided into two categories, that is dentine mineralization, where it encompasses about the repair of the dimless enamel and dentine. And the second subcategory is dentine pulp complex regeneration, which is basically dealing with the necrotic tooth. Biomimetics is nothing but a science in which we are trying to replace the damaged portion of tooth with a material which is having similar property biologically, aesthetically, and in function. The flexural strength of enamel is 180 and dentine is 207. But when we come across caries, it is replaced by a composite having flexural strength of 135 megapascal. And when we are doing root canal treatment, which is followed by a PFM crown, it has got a flexural strength of more than 150 megapascal. The Zirconia crown is having highest flexural strength, that is 620 megapascal. Replacing the tooth with a hard material is not a good idea because it causes concentration of stress, which may lead to fracture of the root. Mere aesthetic cannot be overweighed over the strength of the material. Ideally, the material which is replacing the natural tooth substance should have equivalent or near equivalent flexural strength, Young's modulus, and hardness number. Comparing it with the enamel and dentine, composite is relatively a better material of choice. Just observe and appreciate the wooden handle of the axe. Suppose it is replaced by an iron handle, what will happen? With the use of this iron handle axe, it is going to hit or give jerk to the hands. So even if we are replacing the soft wood with a strong iron, it is not going to have same function and same comfort to the individual. The same principle is applicable for selection of the restorative material in the patient. So what is our criteria? The ideal criteria is that we should select a biomimetic material which is having same form, similar function, and similar aesthetics. This biological material can be prepared artificially or it can be prepared in situ, but it should have same form, function, and aesthetics to get ideal restoration or repairing of the original tissue. Just imagine the difference between the traditional dentistry and biomimetic dentistry. In biomimetic dentistry, we always try to have small cavity preparation with adhesive material. Whereas in the conventional dentistry, a large tooth substance is prepared with the help of burr and is restored with some material which is not mimicking the original properties of the tooth. When it comes for the crown, we should always select a crown which requires a minimal preparation and should have good adhesive property. When it comes for root canal treatment, the root canal treatment should be conservative, access opening should be conservative, canal cleaning and shaping should be conservative, and the sealer which is used should be biocompatible and should always have remineralization property, as we have got the tricalcium silicate based sealer in recent time. The biomimetic materials are dependent upon, protocols are dependent upon two, that is stress reduction and enhancement of the bonding. In this case, the stress reduction is achieved by the use of onlay, inlay, and overlay. Added composite restoration always causes formation of stress because of polymerization shrinkage. The reduction in the increment of thickness of composite will always reduce this shrinkage or the stress which is formed after the restoration of the composite. The fiber reinforced composite at the dentine level also helps us to dissipate the forces of the occlusion. Slow polymerization by light cure unit in a ramp or intermittent pattern will also reduce the stress concentration in the composite. The dentine should always be replaced by a flowable composite rather than a condensable composite. If in case the thickness of the restoration is more and it is going to start from the pulp chamber, then a dual core composite is preferred over the regular condensation composite. It is imperative to remove the dentinal crack within 2 mm of the DEJ because it is the weakest area where the stress will be concentrated and which may lead to failure of the restoration. The stress of the occlusion can also be dissipated with the help of canine guided occlusions. The canine guided occlusion is created by having a composite restoration on the palatal fossa of the maxillary canine and the buccal surface of the mandibular canine. The other technique for biomimetic protocol is to increase the bond strength. The bond strength can be increased by repairing the original composite restoration. This repairing is done with the help of silane. The bonding strength of the composite is dependent upon the hybrid layer. This hybrid layer can be reinforced by using chlorresidin, which is an anti-MMP action. The beveling of the enamel increases the surface area, and the immediate dentin seal is a concept which should be employed whenever we are going for indirect restoration. The elevation of the gingival box also increases microtensile bond strength by 30%. Peripheral seal zone. The peripheral seal zone plays an important role for increasing the longevity of the restoration. The peripheral zone means that a zone of healthy dentin and enamel should be created around the lesion. This zone should be 2 to 3 mm in width, and it should have a ring of enamel followed by DEJ, which will be followed by the dentin, and the core area will be the caries lesion. The next thing which is important to increase the bonding strength is the immediate dentin seal. As discussed, immediate dentin seal means that we are applying the bonding agent on the dentin and we are removing the bonding agent from the enamel. The care should be excised that the bonding agent should be limited till the dentin only without coating the enamel. This will help us to increase the bonding strength by 40 to 60 megapascal. The restorative materials that we are using conventionally are glass enamel cement. So glass enamel cement is also called as a dentin-like cement, artificial dentin, and it helps us to have same property of dentin. It has got fluoride releasing property which prevents the occurrence of caries. There are multiple modifications in the conventional glass enamel cements, but most of them are not being marketed. Resin modified GIC is the improved version of glass enamel cement in which the resin is added to the liquid and the powder. The improved version of resin modified GIC is the compomer. Compomer is nothing but a resin in which polyacids are added. It contains glass filler along with polyacrylic acid powder in a resin matrix, but all of them are different. In geomer, it is a modification of compomer in which the glass filler particle is coated with the polyacrylic acid. So it has got a pre-reacted glass in which the polyacrylic acid coat is there over the glass, and on which there is a coating of silane. This silane coating helps us to join the filler particles with the matrix, and pre-reacted glass particle is also helpful to release fluoride in ample amount. So it gives anti-caries effect with the fluoride releasing property, and it has got resin matrix for imparting the strength. Santion N is a modification of geomer. In this, they have used a different resin. It is urethane dimethyl aliphatic PEG 400 DMA resin. It has got patented isofiller particles which have got cushioning effect. It is an alkaline filler which causes release of calcium, hydroxyl and fluoride ion in the acidic environment. And this is the reason why this material has got good strength and it has got fluoride release equivalent to Equia forte. The fluoride release of Santion N is lesser than Beautiful 2. There are multiple advancements in the restorative materials like Doxadent. It is an aluminum and lithium based material which comes in the powder liquid form and has got strength equivalent to GIC. The incorporation of polymeric fibers in GIC also increases the strength of the GIC. Ceramide is a new advancement in which the hydroxyl apatite crystal is added and it leads to formation of it is a restorative material which forms a hydroxyl apatite crystal in reaction with the saliva. White amalgam is nothing but the addition of nano hydroxyapatite crystals with zirconia in the glass ionomer based cement. It helps us to have higher strength, better biocompatibility, and higher remineralization property. The latest advancement in composite is the self-healing composite. Self-healing composite contains microcapsules of polyurea formaldehyde or silica, which contains resin. Under stress or crack formation, this capsule bursts, and as it is burst, the resin is released from the microcapsule. There is a catalyst in the epoxy resin which causes polymerization of the released resin from the microcapsules, and it fills the gap. So this is a self-filling composite which can handle the crack or fracture of the composite. Coming to the ceramics. Now ceramics are divided into three categories. One is the ion releasing ceramic. Now bioactive cement is a classic example of ion releasing ceramic. It releases calcium and hydroxyapatite crystal in ample amount in the acidic environment. Ceramic coating on implants helps us to have osseointegration with the bone. The other advancement in the ceramic is the hybrid ceramics. So hybrid ceramic is nothing but a combination of polymer which is infiltrated in the feldspathic ceramic network. The feldspathic ceramic network is stronger, and the polymer infiltration imparts the strength and aesthetic to the original framework. Holland et al. Has also prepared an apatite lucid ceramic which has got similar strength and aesthetic. Coming to the biomimetic regenerative dentistry. In this, the author has divided into two, that is dentin remineralization and dentin pulp complex regeneration. Please appreciate the picture. In this, you can see the enamel, which is mineralized, and this diagram shows the decalcified enamel. Similarly, this is the healthy dentine having peritubular dentine and dental tubules and the intertubular dentine. And this is the decalcified dentine in which you can only see the collagen bundle without any calcification. In situation like this, where there is some amount of demineralization, it can be cured or treated by the crystalline growth mechanism. Whereas the situation like this, when there is complete loss of minerals and only inorganic portion is sustained, this is repaired by the non-collagen based protein. The non-collagen based protein helps us to form the nucleation of ACP molecules and then formation of hydroxyapatite crystal in bulk to repair this structure. What are we going to achieve in remineralization? So remineralization means that we are going to adhere the hydroxyapatite crystal on the collagen bundle. Hydroxyapatite crystal is nothing but it is formulation of calcium, phosphate, and hydroxyl ion. So in this diagram, you can see that the hydroxyl ion is in the center, which is surrounded by the calcium and then surrounded by the phosphate ions. This phosphate ions joins the multiple calcium ions together, which leads to formation of the hydroxyapatite crystal in the needle form. These are the materials which can help us to form the repairing of the decalcified enamel or dentine. So nano bioactive glass, enamelon, theobromine leads to formation of hydroxyapatite crystal. Arginine and bicarbonate has got a unique purpose. Arginine catalyzes the fluoride for uptake and carbonate creates an alkaline environment. So this helps us to form the fluorapatite crystals, which is resistant to demineralization as compared to hydroxyapatite crystals. Self-assembling peptide, it creates a 3D scaffold which helps us to have nucleation of hydroxyapatite crystal, and it increases the stable formation of hydroxyapatite layer over the demineralized surface of the tooth. Iontophoresis. Iontophoresis is nothing but the movement of calcium and phosphate ions under the influence of the electric current. The potential difference in the electrode drives the movement of the calcium and phosphates, which causes deposition in the demineralized area. The other materials which are helpful or potent for demineralizations are nanohydroxyapatite, tricalcium phosphate in alpha and beta form, CPP and ACP, that is casein phospholipid and amorphous calcium phosphate, is the potent material for demineralization of the demineralized tissue. The unique property of CPP helps us to create a reserve of ACP ions, and it absorbs calcium, zinc, manganese, and selenium ions in a large amount. Whenever there is drop in the pH, these ions are released and it decreases the calcium in the plaque and saliva. The supersaturated calcium and phosphate in plaque and saliva helps us to have remineralization of the tissues. The other materials like sodium calcium phosphosilicate, calcium sucrose phosphate helps us to form hydroxyapatite crystal in large amount. Xylitol is a unique material. It is a sugar alcohol. It has got antibacterial property and anti-plaque agent. Due to its anti-plaque activity, the concentration of the Streptococcus mutans in the plaque is reduced, and it leads to reduction in the caries in a dramatic way. In case of loss of minerals in higher concentration, the organic substance of the tooth is maintained, but the potential of having remineralization in the same structure is negligible. It is only possible if there are non-collagen proteins which helps us to have nucleation of ACP and hydroxyapatite crystal from the basic concentration. So to start with, polydopamine. Polydopamine is nothing but a dopamine, and an oxidized dopamine helps us to have addition of the hydroxyapatite crystals on the collagen to promote enamel and dentin formation. Similarly, polyvinyl phosphonic acid, it is an anti-MMP material. So it maintains the integrity of the collagen bundle of a demineralized structure, and it causes remineralization of the tissue. Polyacrylic acid also stimulates the calcium phosphate formation. Polyamide, it is also a unique non-collagen protein which helps us to have absorption of calcium and phosphate so that it will be accumulated in the higher concentration, which will lead to sequestrum to form hydroxyapatite crystal. Sodium trimetaphosphate, it is a phosphoryl and phosphorylated collagen type 1. It aids in nucleation and mineralization of the dentin. Coming to the next point, in which the tooth pulp is lost. and it leads to decreased dentine thickness. This kind of teeth are probable to have root fracture. So the materials which are used for regeneration of the pulp are calcium hydroxide, MTA, biodentine, and amdogain. Calcium hydroxide forms the calcium salts and calcium protein complexes. The OH ion is antibacterial and it causes release of alkaline phosphatase, which is required for the mineralization. MTA, it causes biomineralization and it has got antibacterial action. The hydroxyapatite crystal formation is there when the MTA reacts with the phosphate buffer. Biodentine is a novel material. It is also called as artificial dentine. It causes differentiation of dental progenitor stem cells due to release of tumor growth factors beta 1. Amdogain is nothing but an enzyme which is purified from the enamel of porcine tooth bird. It is rich in enamel protein like amylogenin, enamelin, amyloblastin, amyloidin. It forms a matrix which has got affinity to hydroxyapatite crystals and collagen. So when we compare the pulp capping agent for the DPC of our maturogenesis or revascularization, Theracal PT is a new resin-based material which can be used for pulpotomy and DPT, whereas Theracal LC is used for IPT and DPT. When we study about the calcium release of all these materials, biodentine has got the highest amount of calcium release, followed by Theracal PT and Theracal LC. The cytotoxicity of Theracal LC is more than Theracal PT and biodentine. So biodentine is the best material for revascularization and maturogenesis. Coming to the next point is about cell homing. Cell homing is nothing but the plantation of cells which are originally present at that site in the body. So it deals with the recruitment of stem cells or progenitor cells to achieve the tissue regeneration. Cell homing is done with the help of 4 methods, that is platelet concentrates, which is achieved by platelet-rich plasma or platelet-rich fibrin. Bone morphogenic protein, because it is present in the bone, enamel and dentine. Enamel formation is carried away with the help of BMP4 and BMP5, and dentine formation is achieved with the help of BMP2, BMP4, BMP6 and BMP7. Hyaluronic acid forms the basic structure of glycosaminoglycans, which is the integral part of extracellular matrix. It influences the growth factors and it forms the matrix for regeneration and mineralization. Collagen also forms the basic structure of extracellular matrix. So to conclude, regeneration and repair assisted by the biological material is the best solution for ailments in human beings. The biological properties in the artificial restorative material will result in long-term success of the treatment. Thank you.
Thank you, Dr. Neelesh. It was a wonderful description you gave and a thought-provoking what best suitable material can be there when we have to replace the national tooth. So it is really a wonderful, a lot of work has to be done and a lot of research has to be pulled in to find out which is the best material. And you gave the qualities, properties, why this should not be taken care of. why this material should not be used. So this is very informative and very, I said, thought-provoking for the young graduates, postgraduates to work into it and find the best suitable material to replace the natural tooth.
Thank you, sir. Thank you very much for the appreciation, sir.
Thank you, sir. Sir, there are some questions in the question and answer section. We can answer it live in the question and answer section, sir.
I think
Yes,
Dr.
I'll go ahead with this.
Nagarathna can take up the questions, and because I'm not able to, I had requested her to see if she can have an access to these questions, and so that she can ask questions and whichever things can be, conveyed to the students and their queries answered very well.
I think Dr. Neelesh is already typing the answers in the chat box. Am I right, Dr. Neelesh?
Yes, sir.
Are you finished with all the answers?
Sir, I'm doing it, sir.
Okay. Pandit sir, I think he's already doing it. So
Okay, that is great.
Yeah.
I thought that it was sometimes I get.
No, he will be there for a few more minutes.
Time to.
No, he will be there for a few more minutes, and maybe he will take up all the answers, questions. And Neelesh, is it possible that you give some reference material to read? Maybe you can email me some reference material so that I can share with the in the Telegram group with the live members as well as the student members. And I'll try to attach in the chat box also if it is possible for you to share few of articles which are for good reading.
Yes, sir. I have got 15 articles on this topic, out of which 3 are prominent, especially.
Yeah. Just
by
email me
Singer.
all those 3 right now if it is possible for you to do it.
Yes, sir.
Dr. Vidya, I think these all presentations are on our website, and everybody can have access to this. And then it is the better thing that if material is also available, so they can really go through it in an exhaustive way.
Yes, sir.
In their own times. Yeah.
Yes, sir. Yes, sir.
Good.
Sir, I am thankful to the ISPPD team and the Madhu sir and the ISPPD head office for giving me this opportunity to present this presentation on this topic.
And Neelesh, your input has to be sought. I just told Dr. Virender, they will involve you because you have so much of fertility in your mind, so much of research going on in your mind. So whatever ISPD can help you sail through this system and convey to the people. So many things have to be added.
Yes, sir.
You stay in touch with Dr. Goyal. Huh?
Yeah. We discuss it after that also, sir. And we are on it, and definitely we will do something really good. Yes, in future.
Yeah.
Sir, there is a student who is asking for the presentation. So with the article, I can share the presentation also.
Yeah, that's absolutely wonderful. You can modify your presentation, whatever the data you don't want to share, it's okay. Like some patient, if some picture is there, and after that you convert it into PDF and then share it with me. I'll share it with all.
Yes, sir. I'll mail it to you, sir.
Perfect. I'll wait for your mail. Thank you.
Thank you, Neelesh. Thank you so much.
Thank you, sir. Thank you very much.
Thank you, Neelesh, sir. Now I would request Mr. Dev to display the certificate of appreciation for Dr. Neelesh, sir.
Wonderful. The certificates have come out very nicely. They are very aesthetically very sensible.
Thank you, sir. All credit goes to our Vasudev.
Oh.
Yes, sir.
Good job done by Dr. Vasudev.
Thank you,
Sir,
sir.
he is the IT person, sir.
IT department.
Basically.
Okay.
Yes, sir.
So next, we'll move to the next topic, that is stainless steel crowns. I welcome Dr. Priya Subramaniam, ma'am. I would request Dr. Nagarathna, ma'am, to welcome Dr. Priya Subramaniam, ma'am.
Good afternoon, everyone. Am I audible?
Yes, sir.
Okay, thank you. It's my privilege to introduce Dr. Priya Subramaniam, who is a well-known pediatric dentist, also holds FTS RCPS from Glasgow. She is presently working as a principal and professor of the Department of Pediatric Dentistry at Oxford Dental College, Bangalore. She is one of the resource person of Rajiv Gandhi University of Health Sciences in various academic activities. She is a guide mentor for students of postgraduate studies and postdoctoral studies of RGHS. And she's also been an external examiner for PhD program of University of Melbourne. And then she's a member of the Journal of Clinical Pediatric Dentistry, also identified in earlier as one of the top 15 most productive authors in the dental research in India. And her research interest includes on early childhood caries, pulp therapy, saliva, special children, and she's got over 90 research publication by herself is an achievement. She's also plays an active role in delivery of the oral health care to underserved children, and then participates in school dental health programs and also the dental care towards the special health care needs. Ma'am, the presentation is going to be all yours, and we are very happy to be listening you here. Thank you.
Welcome, Dr. Priya Subramaniam.
Ma'am, you have to unmute.
Oh, sorry. Can you hear me now?
Yes, ma'am.
Yeah.
Yes,
Yeah, I
welcome,
just
Dr.
wanted
Priya.
Thank you. Good afternoon, everyone. A special thank you to Dr. Madhu and team and Dr. Virender Goyal. Thank you, Dr. Nagarathna, for that kind words. And sir, thank you, Dr. Pandit.
I would request Mr. Dev to display the presentation.
I'm Dr. Priya Subramaniam, speaking on stainless steel crowns. Stainless steel crowns are prefabricated crown forms which can be adapted to individual primary or permanent teeth and cemented in place to provide a definitive extracoronal restoration. They were introduced in 1947 by the Rocky Mountain Company and popularized by Engel and also William Humphrey in 1950. The crowns are stainless steel of austenitic variety, and they have chromium 18%, nickel 8%, and carbon 0.8 to 20%. The nickel chrome crowns contain an alloy of 77% nickel, 15% chromium, and 7% iron. These crowns are available in 6 sizes for each primary tooth and permanent molar, and the sizes 4 and 5 are commonly used, and size 7 is used for extra large teeth. Coming to some of the mechanical properties of stainless steel crowns, they have a good Fresnel hardness number of 154, and they can be formed and contoured, and because they are ductile, and they can be work hardened while you crimp the crowns. The types of stainless steel crowns, you have untrimmed crowns or straight-sided crowns, which are bulky. They're neither trimmed nor contoured, and they require extensive trimming and much adaptation. The pre-trimmed crowns are the Unitec crowns, which have straight sides and are festooned to follow a line parallel to gingival crest. They require some amount of contouring and trimming. The pre-contoured crowns are also festooned, pre-contoured to closely resemble the natural tooth, and minimal trimming and contouring may be required. There are several brands of crowns in the market, and each brand available on the market has a slightly different composition. Coming to the indications for crowns for primary teeth, it is a matter of choice that you have to place a stainless steel crown in molars with 2 or more caries surfaces and expected to exfoliate up to 2 or more years. Also, it's mandatory for doing pulp therapy because the tooth is brittle and the crown takes up the occlusal stresses. Other indications include children who are at high caries risk, like early childhood caries, when repeated visits are not possible for monitoring restorations, primary molars with enamel hyperplasia and developmental defects, children who have some amount of occlusal wear due to attrition, bruxism, tooth and infra-occlusion like an ankylosed tooth. Also for reverse anterior stainless steel crown can be given for correction of a single tooth in crossbite as an abutment for space maintainers in children with special healthcare needs These are the indications. Definitely not indicated when the tooth shows more than half the root length resolved, tooth nearing exfoliation, pre-shedding mobility, or children who are sensitive to nickel or allergic, and if you're not able to adapt the crown due to lack of preparation or not enough root structure. Coming for the indications of stainless steel crowns for permanent molars, they can be given as an interim restoration for a broken down or a traumatized tooth. When there are some financial constraints, it can be used. Also in developmental defects or a partially erupted permanent molar with cervical caries, or children, even adult patients with special needs, they can also be given this crown, or people in remote areas. The advantages of giving stainless steel crowns is that in uncooperative children, like instead of calling these children several times and being worried about the longevity of any restoration, you can give a crown. Also, the outcomes of pulp therapy, which are treated with SSCs, are much better. There's a high survival rate and longevity of stainless steel crowns. And this article brought out in the Iranian journal gives you a review of several other works on stainless steel crowns and their survival, which is ranging from around 86% or to even 100% for 18 months and 64% at 33 months. The advantages of using these crowns in permanent molars is it reduces the risk of recurrent caries. In the mixed tension period, it retains the arch length, and in teeth treated with molar incisor hypermineralization has a high success rate. What is the armamentarium that you require for this? Now here I'd like to tell you that all of us are aware of the burrs that we use and the polishing kit, but you need to arrange your armamentarium well on your trolley or on your bracket table, a stand, the plier stand, and a set of complete sterile instruments and a separate sterile pouch for diagnostic instruments. A rubber dam is a must, so you need to know the components of the rubber dam, whether it's the frame, the rubber dam sheet, the clamps, tying the floss to the clamp, and you need to know the dimensions. Also, local anesthesia is to be given, so you need to know the composition of local anesthesia, the technique of administration, what are the precautions you take in children, what are each component of the local anesthesia, whether it's topical or you're going to inject, what is the use of each ingredient in the solution. The dental floss used is a knotted one, and the different pliers that you have on the plier stand, you have to have at least the Johnson Contrin plier, the Pulp plier, and the Abel ball and socket pliers. The whole pliers can be an option. So coming to occlusal evaluation, prior to the rubber dam application, you need to check the dental midline and also the cusp-fossa relationship on both sides. See if there is any opposing extruded tooth and see if there's any mesial drifting of a tooth. And you can see this either directly in the mouth or you can see it indirectly on a model. And you can also record a black spite if required. Coming to rubber dam isolation, you know the benefits of isolating with a rubber dam. And you can also use a wedge or a matrix band to keep the tooth separated or slightly apart. And the band will prevent any iatrogenic damage to the adjacent tooth. Remove the caries, and also the pulpotomy procedure can be done before or even after crown preparation. Now coming to selection of crown, either you measure the mesodistal width of the tooth before the tooth preparation directly in the oral cavity, directly on an intraoral radiograph where you have to consider magnification error, or on the model. And crown selection can be done after tooth preparation. Remember to select the smallest crown that covers the preparation, closely fits the tooth and restores the interproximal contact. Be careful in seating this completely because then you will not be able to remove it otherwise. And coming to administration of local anesthesia, you may wonder if it's already a pulp treated tooth, it's not vitally right to use local anesthesia, but an infiltration would be necessary because you are going to touch the soft tissues. There will be some amount of manipulation there and the child will have some discomfort. And rather than just applying topical, you could give a local infiltration. Preparation of coming to the preparation or the tooth preparation. That is, you have the authors which say start with the occlusal, which is most popular. And some authors say that why not start from the proximal side. On the proximal side, there could be, inadvertently, if you have exposed the pulp, you will mistake the gingival bleeding and you will not be able to realize that there is a pulp exposure in white teeth. So coming to occlusal reduction. You start with depth orientation grooves, which are prepared with the tapering fissure burr, which is this 169L is an end cutting taper fissure burr. So you make depth cuts of 1 to 1.5 millimeters, the mesodistal and buccal direction, and then you cut through the marginal ridges and the complete buccal and to the buccal and lingual surfaces. With the side of the burr, you uniformly reduce now to this depth of 1.5 mm, maintain the cuspal incline such that the tooth looks as a miniature molar. And if suppose the tooth is already, the occlusal surface has lost to caries or because of pulp treatment, then use the marginal ridge of the adjacent teeth as a reference. So these are pictures where they've used a football-shaped burr to place the depth orientation cuts and then reducing the tooth. So coming to proximal reduction, a thin tapered fissure burr is required to break the mesial and distal contacts. And this burr should be held at an angle, maybe 10 to 15 degrees to the long axis would be sufficient. You've got to go along the entire length of the crown so that there is no ledge formation on the proximal sides. Reduction, minimum 0.2, that's the thickness of the stainless steel crown. But you can say about 0.5 mm is also all right. Proximal slices have to converge towards the occlusal. Any mistake in this angulation can result in a ledge or a shoulder preparation, which you do not want. Coming to buccal and lingual reduction. According to certain authors, you don't need to touch them because you need the buccal bulge or the palatal bulge for retention, even that cusp of carabelli. But according to certain other authors, if required, if the buccal bulge is is interfering with the placement of the crown, then you can limit your reduction to the occlusal 1/3, 0.5 to 1 mm on both surfaces can be done. All line angles and sharp corners should be rounded. The occlusolingual and occlusobuccal angles are rounded by holding the burr at 35 to 40 degrees angulation to the occlusal surface and sweeping it in a mesodistal direction. Remember that there should not be any sharp corners. So even the buccal and lingual proximal line angles are rounded off by holding the burr parallel to the long axis. The rubber dam can be removed after tooth preparation. Now you can try on the crown for a lower molar, you're going to place it on the lingual and slide it over the buccal surface. It should snap with an audible click. And if you find that the crown is a bit high, that means your occlusal clearance is not sufficient. You've not reduced it occlusally enough. The crown may be very long. There could be a proximal ledge. You've not broken the contacts at all. And please be careful about gingival blanching because excessive gingival blanching could indicate that the crown margins are, impinging on the epithelial attachment. So for this, how do you establish the cervico-occlusal height of the crown? We can use Spedding's principles given in 1984. For this, the untrimmed crown is placed over the prepared tooth. You make 3 slide marks with either a sharp instrument like a scale, carver or a number half round burr. You mark the heights of the gingival crest at these levels of the buccal and the lingual. Remove the crown, trim it in a straight line about 1 millimeter. You leave 1 millimeter and width, and then below that, whatever crown is available, you cut that with a crown and with scissor or with a carborundum V. Take care not to cut it in front of the patient's face and even have your protective eye gear on so that any slivers will not impinge on you. And the other thing is any flash that is produced is also removed with this heatless stone and repeat the procedure till the adequate extension of 1 mm beneath the gingival margin is achieved. Second principle of Spedding is regarding the shape of the stainless steel crown margins, both the buccal and lingual marginal gingiva. In the second primary molar, as we know, it follows a smile or resembles a smile, and the first primary molar, you see the buccal marginal gingiva appears as a stretched out S. Keep it in a horizontal position, then S, how it looks. And the lingual margins are again resemble a smile, and all proximal margins should resemble a frown. Coming to adaptation of the stainless steel crown, if you require a bit of belling in the middle third, you use the crown contouring pliers placed at the middle and the cervical third of both buccal and lingual surfaces. In case interproximal contacts are not established and you need that, there's no primate space and you need to re-establish it, you can use a number 112 A-bell pliers or the ball and socket plier. Do not contour the proximal surfaces that are already in contact, and mesial surfaces of the mandibular first molars are flat. Crimping. Now we know that the undercut of the cervical constriction of the crown, of the tooth is constricted. So this undercut is required for retention of the crown. So crimping bends the cervical margin of 1 mm. It bends it inward and into this undercut. So crimping provides mechanical retention. It protects the cement from leaching out to the oral fluids, and also you require it for gingival health. Finishing of the crown. The crown, you use a heatless green stone. As I told you, whatever sliver comes out or the flash that comes out when you are trimming the stone, you have to again flatten the margin and remove this, otherwise it will come in the way of your placement. And you can use a rubber beam to remove any scratches, a wire brush to polish. You can only polish the outside of the crown or the exterior surface, don't touch the inner surface, and you can polish it with even a rouge on a chamois wheel. Crown margin should always consist of a series of curves. Now, before you cement the crown, it is optional. If you don't mind, exposing the child to radiation, you can have a bite-wing radiograph taken just to assess the proximal contacts and the extensions. Coming to isolation and cementation, whatever eluting cement you use, you need to first isolate the tooth, dry the tooth, and then you wash the crown, rinse it, and dry it, remove all the blood stains and the saliva. And after drying it, you have to know about your eluting cements. You need to know the composition of your eluting cements. You need to know the powder liquid ratio, how you manipulate the cements, what are their properties, especially with regard to the film thickness of the eluting cement, as well as their solubility in the oral fluids. So the cement is mixed on the glass slab or on the mixing pad, taken in the spatula, and you fill up the crown to at least 2/3. Pass it all along the margins of the crown such that avoid any air bubbles and voids. Now, when you place the crown in the child's mouth over the tooth, support the child's mandible as it is seated, and then place it gently over it and ask the patient to bite on the cotton roll placed over the crown, or the orange wood stick, or orthodontic band seater. The cement has to be expressed from the margins like a flash. If it doesn't, that means your cement is not adequate. The patient must bite in centric occlusion before the cement sets, and the crown should be kept dry during setting of the cement. Remove all the excess cement from the margins with a scaler or with a spoon excavator before it sets completely and adheres to the gingiva. So interproximally, you use a knotted dental floss, and the floss will remove any cement that's wedged in the interproximal area. Check the occlusion at soft tissues. You could have initial minimum gingival blanching. That's only transient. And oral hygiene instructions are a must for the child. What are the eluting cements? It depends on, depends on the cost, depends on the remineralizing effect. So generally, glass ionomer type 1 eluting has been used. You can use even zinc polycarboxylate, zinc phosphate because of its low pH, not really recommended. Reinforced zinc oxide eugenol or even resin modified glass ionomer cement is shown to be better than the conventional GIC, and even self-adhesive resin cements have been shown to be good. But sandblasting the stainless steel crown or placing retentive grooves on the button surface of the tooth really did not increase their retention. Now, retention, as I said, depends on tooth preparation, the crown adaptation, as well as your eluting cements. So the undercut and the placement of your gingival margin is very important. How do you prevent aspiration or ingestion of the crown? The chair position is very important. Don't allow the child to be in the supine position, and you can attach a floss or a folded autoclave tape or elastoplast like a parachute handle to the crown so you can easily retrieve it. You can place a throat pack with some gauze, use effective isolation, high vacuum suction, and in case you can't find the crown, then and you think it's gone in, then you have to pat the back of the patient in a prone position so that it comes out, or you do a Heimlich maneuver. Otherwise, you need to refer the patient quickly for a chest radiograph, and it has to be removed by a bronchoscopy. What are the problems that you can face? Rocking of the crown. The crown selected may be too large, or it may be extended or too wide. The crown could be slanting to one side. So that means your occlusal surface reduction is uneven. You may not have rounded all the line angles. Other problems that you can see which are there, which you can be asked of, could be if you have extensive caries. Now, generally, the outline for a rectangle, the lower arch is a rectangle for a lower primary molar. So, in those cases, you might have to reduce the buccal and lingual surface and make it more of a squarish outline. Whereas in the upper arch, the outline will become more square in case of adjacent extensive caries. What are the other modifications according to Nash? If you have two adjacent stainless steel crowns to be placed in one quadrant at the same visit, then you have to do it at the same appointment. What you need to do is you need to pair the teeth. So first you do the occlusal reduction of one tooth, then you do it for the other. Don't do both together because you may reduce. And then you need to have slightly more reduction in the proximal surfaces so that there is 1.5 mm space at the gingival level. It will be easy to place both crowns. And both crowns are trimmed, contoured, and prepared for cementation simultaneously. But you first place the crown which is distal or the posterior most one, and then do the medial one. Now, what happens when you have a tooth to be crowned and adjacent to that you have a carious tooth, the proximal caries? First, you need to place the crown. It should not extend into this other tooth, and the other tooth has to be treated with a matrix band and the restoration given. In case of a deep subgingival caries, you can solder a flange to the stainless steel crown in that particular region. And before the eruption of the permanent mandibular first molar, you have to be careful. If you're bringing a patient with only primary teeth and the first permanent molar is not erupted, then you need to be careful because your cervical overhang, the crown margin, should not interfere with the eruption of the tooth. In case of occlusal wear or bruxism, then you can add some solder to the inner surface of the crown to restore the vertical height of the occlusion. The Mink and Hill modification given in 1971 is for the oversized crown and the undersized crown. So in an oversized crown, it's just like your clothes which are oversized. You have to give them for you kind of cut it down. So the same way here, what you do is you make a cut along the front of the crown from the gingiva to the occlusion, depending on which crown. So you don't want the cut to be seen. So in the lower arch, you can do it on the lingual, and in the upper arch, you can do it on the palatal. And after that, you can bring the bring both the edges together with the hole plier and flatten it, and then you can solder it, weld it, or spot weld it, and you can add some solder and flux. Only thing is you need to make sure you polish it well. Other procedures will be safe. Then in undersized crown, you can cut a V in the crown on the buccal and on the lingual side, or both if required. And in this V, the V that you've cut, you can spot weld a stainless steel band material and use again the howl plier to flatten it, and then you do a spot welding and the same procedure. Now, you can't use stainless steel crowns when there's a nickel allergy. So it has been reported in patients where the primary molar roots have absorbed nickel. The longer the crowns are in the mouth, the higher the nickel could be leached out. And the allergies could be in the form of hyperplastic gingival tissue in the region of the crown. So you have to be careful in these cases. Main reasons for failure of crowns are crown loss, that maybe the cementation has failed, and perforation. And other reasons can be at every step if you've gone wrong, if you've not done a proper pulp therapy, you've not removed the caries, you have caused improper tooth preparation, selection of the crown. So anywhere if you've gone wrong, it can be a cause for failure. So there are many studies done on this. Some of the studies I would like to say that in case of a permanent first molars when you give a crown, because of the continuous tooth eruption, you'll have to kind of monitor and change the crowns. Otherwise, you'll have formation of ledges. Another one is when they have reported that people who don't maintain good oral hygiene, the gingival index would be high and a lot of subgingival microbial counts. Also, the macrophage inflammatory proteins were increased in the GCF. More gingival bleeding has been seen with these crowns compared to glass eye in the restoration. And also in adults with special needs, it was found that the crowns survived for 10 years, much more than an amalgam restoration. Now, coming to the Hall technique. The Hall technique was practiced by Dr. Nona Hall in Glasgow or in Scotland for about 15 years, and following which in 2006 she retired. And these crowns were then popularized by by Dundee University by Dr. Nicola Hines. So the main aim of this whole technique is to increase the compliance of the anxious child and also an operator's comfort. It's a very quick, non-invasive procedure. So you don't give LA, you don't remove caries, you don't do a pulp therapy, you don't do a tooth preparation. What is the biological principle here? You just seal in the caries. So the caries is sealed and it is out of contact with the substrate and the oral fluids or the oral environment. So that is why the caries progression gets, it is retarded, or the caries gets arrested, and there is a higher chances of pulp survival. So it always, but this crown, when you give a Hall technique, you should, the child should maintain good hygiene. So the indications would be occlusive caries, non-cavitated, if the patient is unable to accept sealants or any caries removed in a conventional way. Same thing with proximal caries, either cavitated or non-cavitated. And you must have sufficient sound tooth structure to retain them. Contraindications would be anyone with infection or irreversible pulpitis. Crowns, tooth structures totally gone, you can't give a crown. Very young children who cannot understand the concept of biting on the crown without local anesthesia, and children who are immunosuppressed or who are infective endocarditis, definitely you can't do this. What is the technique? At the first appointment, you need to place orthodontic separators, and please make sure you place dental floss to the separator, so it makes it easy able to pass the separator between the elastic between the teeth. And beyond that's at the contact point, and you leave it there for 3 to 4 or 5 days. Patient comes back, and you have the space. The crowns can be placed, and it gives a good, has to cover up the entire tooth, all the cusps, and adjustments of the crown can be made if required. Otherwise, you just cement it with your gluting glass and the cement. There will be a bit of increase in the occlusal height, but this gets readjusted with a few weeks due to dentoalveolar compensation, and that is only transient. The concerns of the Hall technique is that you may need an additional visit. So, if you're going to place separators, you need to call them again. Second is, since there is no occlusal preparation, it leads to premature contacts and increased occlusal vertical dimensions. So this is only temporary, as I said. And the other concern is a child has to bite on this hard crown metal surface through these tight contact points with no local anesthesia. So that could be a concern. Advantages: non-invasive, no need of any tooth preparation, very short and quick, it helps a lot in general practice. And children who are, then it won't be so traumatic and very cost effective. There are a lot of evidence-based studies which have been mainly by Nicola Hines and her team, that it shows that it is very useful, especially in cases of when they found it hypermineralized second primary molars. It was well tolerated and it's better than the conventional method. So I'd just like to mention one thing here about pre-veneered stainless steel crowns. Generally, they're used for the anteriors. My presentation is mainly on the posterior teeth. So one study which is good for a 3-year study by Anne O'Connell at Dublin University is the posterior veneered stainless steel crowns, which showed quite a lot of success. But the disadvantage with this veneered stainless steel crowns is the fracture of the resin facing. So the parents should be told about it. Same thing, you can cut a window on the buccal surface. This was done earlier, but it's more cumbersome. And these facings tend to discolor with the food, and they tend to get lost over time. Whichever type of crowns, and these facings are all attached with different mechanisms, whether it's the kinder crown or the new smile crown or the Cheng crowns. With this, I'd like to give a few questions. That is, discuss various preformed crowns. This involves all types of preformed crowns. And then how about evidence-based studies on stainless steel crowns? The Hall technique, with the merits and demerits on the Hall technique. Clinical exercise is for 50 marks. So it's very important what to select, with adjacent teeth and with an opposing teeth present. And don't take children with a very deep bite. It would be difficult for you. Then armamentarium, you have to have everything, as I said, rubber dam application. At every stage of your clinical exercise, questions can be asked. And yes, thank you.
Thank you, ma'am. That was a very good and informative, crisp presentation. And then, of course, there are a lot of questions in the chat box. Dr. Madhu, shall we direct these questions to the mail?
Okay,
Sir?
Okay, ma'am. So, madam can take a few questions.
in the question and answer sections, there are a few questions, ma'am.
Madam, will you take up the questions or shall we address it later on?
Yeah, you could just tell me. I mean, I'm not able to visualize that. So,
Yes, ma'am. There are few questions. Ma'am, should stainless steel crown be trimmed or not for primary teeth?
if required, generally the crowns that are available in the market, whether it is the 3M or the Euphraidi or kids crown, these crowns come as pre-trimmed and pre-festooned. But at times you might have to, if you know, if the crown selection is good and still there is some amount of increase in the vertical height, or you're not having occlusal clearance, or if the bite is deep, then you may have to trim very minimal the crown.
Actually, also depends on the clinical circumstances where the two
the
size
scenario,
shape
the clinical
form.
scenario.
Thank you, ma'am. How much blanching is allowed initially? How to know if there is a false blanching?
Yes, you'll have to see whether the crown margin is impinging on the gingival attachment. See, when it's placed in the contacts, below the contact in the undercut, it has to be in the undercut against the hard tissue you're going to bend when you crimp. It cannot be, the margin cannot impinge on the gingival attachment. Then what happens is, after some time, there'll be loosening of these fibers, and then the whole tooth becomes mobile. So you have to be careful in that. When we say blanching, we are talking about a very minimal blanching which will settle. We're not talking about excessive blanching due to overextension of the crown, or if the crown margin is, impinging on this attachment, epithelial attachments.
Also, what is the festooning of stainless steel crown?
Festooning is the margins, the contouring of the margin, especially in the interproximal area. You have the caul, you have the interproximal area, which has to be kept self-cleansing. So that margin which is curved, that is called, the margins are festooned to follow the contour in the interproximal area. Am I right, Dr. Pandit?
Yeah.
Okay. And there's, if the team allows, can I take up 2-3 more questions, sir? Virender, sir?
Yes, ma'am.
Yes, sir. Yes, sir. Thickness of SS crown is around 0.2 to
0.2 mm, and each size differs between 0.3 to 0.4 mm between each size as you go from 3, 4, 5, 6 that way. That is, I'm talking about the 3M crowns.
Yeah, yes. That is a standardization, generally from beginning we are following. So the next question. Okay. What is the actual use of aluminum wax pipe taken for occlusion? What questions can be asked related to occlusal bite?
Yes, see, in certain colleges, they follow this recording an occlusal wax bite, wax record, you record it before the procedure, and then again after the procedure to see whether the bite remains the same. You could also use articulating paper. It's not mandatory as far as I can see. You can visualize. If you want to see on the lingual side, probably you can't, but then you can use articulating paper. That will also help you. Basically, you need to know the cusp fossa relationship, whether it is the same after giving the crown, and also the midline, whether there is no deviation in the midline before and after.
What is the belling effect, ma'am?
The belling effect is just to give a little fullness to the crown if it's very flat, but we are talking about the middle and cervical third with the contour. It gives a contour. And
yes,
the other one is the bulging. That is your establishing contacts that's with the Abel plier, the ball and socket plier.
Is it advisable to use a contralateral crown when the size required for the crown of the same arch is not available? Like using a maxillary? Yes.
I think I mentioned that when
Yeah,
you
yeah.
have
It perfectly goes with
mentioned in
that.
the presentation.
Okay.
Yes.
So there is one more question. During SSC trying, in between the procedure, when checking the fit of the crown, if spoon excavator is used for the crown removal, gingival injury occurs. How can we avoid that?
You need to be careful. I mean, how can we avoid that? Means you can be, if you are more careful, you need to place your small spoons excavator, which is not very sharp, which you use for caries removal. It's not that. You can use and you gently kind of remove it from, I mean, see, this laceration of gingiva can happen at any stage. That is due to carelessness. Or if you're being a bit rough while you're removing, you have to be very meticulous because it's going into the sulcus about 0.5 mm to 1 mm.
Ma'am, another two questions. Shall I take it up?
It depends on the time. You could ask Dr. Virender.
Yes, ma'am. Yes, ma'am.
Okay. While scratching for over or undersized crown, which instrument is used? Hand scaler, ultrasonic scaler, and explorer.
Scratching meaning? You mean for reducing the height of the crown, you mean? Marking.
Yeah, marking.
Threading
For
principle,
the
you can
blanching
use a
correction.
sharp, you can use a, what is that?
Scaler.
A burr
Scaler,
or
any sharp instrument
amalgam
which will
carver.
leave, or even the marker
Amalgam
pencil
carver?
will do. Yeah. What happens is the last question, ma'am. You have been really answering, all the questions almost we covered up. So what happens if iron content in a stainless steel crown is more and nickel is less?
See, when we say stainless steel, we are assuming it's got at least 18% chromium, I mean, depending on the type. So we're looking at austenitic. Now, if your iron content is going to be high, then naturally the corrosion level is going to come down, isn't it? So that is, it's not going to be anti-corrosion as a stainless steel, which has the 18.8 composition.
There is one more last question that is, why are the crown sizes usually from E2 to E7? Why does it not start at E0 to E1?
I think that would.
I mean, E0 and E1.
I think that the manufacturers would have to answer that question because right from my PG days, we were seeing only these sizes given.
Yeah, there are few more are there. I think, the time is valuable. Oh, yeah. So, ma'am, since it's important clinical exercise, people are really putting up their own, whatever their doubts they're having. Kindly look into the chat box and please give away the answers, ma'am. Thank you so much.
Definitely, I will.
Thank you so
Thank you.
much.
Thank you.
Thank you so much, ma'am. That was a wonderful presentation. Now, I would request Mr. Dev to display the certificate of appreciation to Dr. Priya Subramaniam.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
I think the next speaker, some of the answers which I think questions which have not been answered because of the sparsity of the time. Priya is very dynamic and she has got such a great experience because of her clinical experience. She should have added some more answers to this. I think the next presentation will really answer some of the questions which must have been there in the minds of the student. I think the next speaker is Dr. Subbalekshmi. She is also very popular and very hardworking pediatric dentist. And shall I? Yeah. And she's a professor and head Department of Pediatric and Preventive Dentistry, Malabar Dental College and Research Center, Kerala. She has done graduation and post-graduation from Faculty of Dental Sciences, Sri Ramachandra Institute of Higher Education, Chennai. She's had an expert training in health professional education, University of Michigan, Center of HPE, SRI, HER, Ramujam Teaching College, Balaji, Vidyapeeth. She has got tremendous clinical experience in clinical research methodology, which she has got expertise from Seattle, Children's University of Washington. Dr. Subbalekshmi has got so many publications in high impact journals. She is an ardent researcher, reviewer for national and international journal, especially in Indian section editor for Kerala Dental Journal from 2021 to 2024, editor Journal of ISPPD has contributed textbook chapters in various in collaboration with various authors. She is also presently the executive committee member of ISPPD 2023-24, 2024-25. As I know Dr. Subbalekshmi, she is a great contributor whenever these sort of academic and clinical meetings are being conducted by ISPPD head office. She is always there to contribute. So she will be definitely telling about this Zirconia crowns and comparing it with other crowns, newer additions, which I think Dr. Priya has done into the stainless steel crown. Now she will tell other crowns, and then what differences for a clinician are there to understand. And then for the students to, when they write the examination, they should be knowing various stainless steel, various crowns, which we can easily use in dental, in our clinical practice. Over to you, Dr. Subbalekshmi.
Thank you, sir. Thank you for such warm introduction and for all the regards. Thank you, sir. So can we start with the recording, sir?
Thank you, ma'am. Thank you for joining us.
Thank you for joining, ma'am.
I request Mr. Dev to present the presentation on the screen.
Good afternoon. It's a pleasure to be talking on zirconia and new crowns in pediatric dentistry. My gratitude to Team ISPPD for giving me this opportunity to share this with all the postgraduates. For the next 30 minutes, we shall be going through a very brief overview about aesthetic crowns which are available right now. And then I start, let me also say that as a disclaimer that I have used AI in the preparation of this PowerPoint, especially with references, and that this whole presentation is more like a rapid review of what you should be reading rather than about introduction or how to do aesthetic crowns. So in the next 30 minutes, we shall look at the rationale behind why we use aesthetic crowns. What are the different types of aesthetic crowns which are available? We look at zirconia crowns which are used in pediatric dentistry. What are some of the other aesthetic crowns? And of course, aesthetic crowns in exam, as that is the whole purpose of this session. So what are the rationale for use of aesthetic crowns in pediatric dentistry? I think very shortly or briefly, we'll be able to put them together as the aesthetic appeal, parental approval, and biocompatibility. Because traditionally, when we look at our the gold standard, the CST count, the problem that we face is definitely, yes, it takes all of us know. Children from the age of as young as 2.5 to 3 years are worried about their friends, and they have a peer appeal. So we have all these studies with us which show that for them aesthetic appeal is important. Also, parents, many parents who are now parents, are also very particular about their children's appearance, and they want the counts to be aesthetically good. And biocompatibility is one important thing, especially with the advent of the zirconia crowns. There has been a lot of improvement which has happened in that field. So these are the reasons why we are looking for aesthetic replacements for pediatric patients. So when we look at the classification of aesthetic crowns, very broadly, based on the material used, it can be classified as polycarbonate crown, strip crown, pre-veneered stainless steel crown, aluminum veneered tooth-colored material crowns, of course, the zirconia crowns and the bioplex crowns. If we classify them according to whether they are bonded or luted, they can be very broadly classified as polycarbonate, strip and jacket crowns, which are basically bonded crowns, and luted crowns, which would include open-faced SSCs, your Schenck crowns, your finger crowns, new smile, whiter white, pedo pearls, of course, are all these crowns will belong to the luted crowns. Now, moving on to the indications of aesthetic crowns, including zirconia crown. According to the guidelines given by the AAPD in 2024, children who are at a higher risk with anterior or posterior decay, extensive decay, large multi-surface lesions, teeth which are pulpily treated, which involve the incisal edge, extensive cervical caries, minimal caries but very poor oral hygiene. These are some of the teeth which are indicated. The other indications include when they have hypoplastic defect, when there is significant tooth loss due to trauma, the psychological benefit of the patient when the patient wants to have a very aesthetic appearance, and also to maintain arch length and posterior masticatory function, and whenever there are any stains or discoloration of the anterior teeth. What are the conditions when we are not going to be giving these things? When the tooth is non-restorable and when the tooth could be restored by conventional means in an aesthetic way, then we may not think of giving these aesthetic crowns. Specifically, if we start looking at some contraindications, for example, for a strip crown, we don't want to be thinking of giving a strip crown when there is severe bruxism or when there is gingival inflammation. Similarly, for polycarbonate crown, crowding, gingival inflammation or bruxism, all no goes. Whereas when we look at zirconia crown, most of the time, except when there is a crowding or severe bruxism, it is something that we will be able to give. Whereas an aluminium veneered crown, when we have crowding, it might be difficult, but otherwise, we will be able to give those crowns. So this may be useful for you. So now, we will look at zirconia crowns a little in detail. Zirconia crowns in pediatric dentistry were probably introduced by the mid-2000, and it is an inorganic metal oxide. It is mainly used in ceramic materials. The best part of it is it has properties which are very, very similar to that of metal. And overall, when we are talking about it, it requires a passive fit, which means we cannot manipulate it by crimping or contouring. So invariably, zirconia crowns require, preformed zirconia crowns require extensive tooth structure reduction. Before we start going into the subject proper, I would like you all to take a note of this article, systematic review, which is published in 2022, which is quite comprehensive and which has a lot of information which could be of use for you for the exam. I have not included the references or tables from this article, but they are a wonderful read and a repository of information for you. So why zirconia, or what is the most important, why, when we look at why zirconia, the one thing that we have to remember is why stainless steel crowns are the gold standard. We've been having many materials after the stainless steel crowns with aesthetic properties, but we were never satisfied with it because of the high strength and wear resistance and biocompatibility which the stainless steel crown shows. Zirconia is one material which has shown similar properties, and especially the yttria-based zirconia polycrystals, which are basically used in our crown preparations, they are very, very resistant to wear, and they have excellent biocompatibility and good resistance. When it is looked at the composition of some of the most commonly available zirconia crowns in pediatric dentistry, one is Neelesh, the other is ISPPD and PediaRare crowns. So when we look at them, we see that most of them have zirconium oxide, which is the highest percentage which is there, with other different fillers which are available. So the teeth crowns are zirconium dioxide, whereas PZ and Neelesh have zirconium oxide. It is important that you know the composition of these crowns, so please do go through them. And also look for any toxicity which can come from any of these crowns. Types of zirconia crowns very rare, can be monolithic and the layered or veneered form. But remember that most crowns that we have in pediatric dentistry, preformed crowns are monolithic crowns. Commercially available pediatric zirconia crowns may be your Zircon, your PZ, your Kinder, and maybe more. So, one of the first commercially introduced zirconia crowns were the ISPPD. They have both anterior and posterior crown, and they have a natural color which is very glazed and shiny, and they have very good aesthetics. Tooth preparation is very similar to that of the stainless steel crowns. The advantage is Verloc technology, which basically, if you can see, are these round indentations which are provided on the inside of the crown. So these help by increasing the internal surface area which is available for bonding. So that is one of the major advantages of the music crowns. Which also reduces less chance of shipping. They are autoclavable and they have good strength. We'll take a short look at one or two of these commercial crowns and then move on to conclusion. So Kinder crowns are also available in natural shapes, and both anterior and posterior crowns are available, and they have a facility which is called as the incisal technology. So this again helps in better bonding and better mechanical retention of the crown. And they have a polishing system which makes sure that these crowns have minimal wear on the opposing tooth. Like I said, they are available for anterior and posterior teeth. They are available in two shades. One is for where, a more whiter one, and two is the natural pedo shade. Right? Sizes are available from 1 to 6 for both the first primary molar and the second primary molar. The other aesthetic crown is the zirconia crown, is the Zircon crown, very similar to the other two crowns. So when we look at tooth preparation for zirconia crowns, now we should look at tooth preparation for a zirconia crown. For the anterior, we start with an incisal reduction of about 1.5 to 2 millimeters, a facial reduction of about 0.5 to 1 millimeter, and a lingual side or a palatal reduction of about 0.75 to 1.25 millimeters. We get a feather-edged finish, that's what we want, and it will be gingival. So this we should be able to do. When it comes to the preparation for a posterior crown, you should remember that we can start with selecting just like in the case of stainless steel crown, probably look at the mesodistal width and see if you can select a crown earlier. In shield preparation, basically with occlusal reduction, the occlusal contour, but by experience, this is what the manufacturer says. By experience, we all know that there is a lot of tooth reduction material loss which happens in case of zirconia crowns. Then after initiating the preparation and doing occlusal reduction, we are going to do supragingival reduction, and then finally we create a margin which we have to refine. Once we have created the margin, refined our margin, then we test for the fit, then prepare for cementation where we stop, arrest all bleeding, and then fill it up and do the position the crown and ask the patient to bite and get our zirconia checked. Remember one thing about trying in this, that there will be no snap print, it will be a very passive of the crown. The trying crowns or the pink zirconia crowns are basically because unlike stainless steel crowns, for us to avoid exposure of the crown to blood or saliva, what we do is we have a autoclavable pink color crown which is available only if the smile kit. It is not a zirconia crown, but it is made of a material which has accurate properties like zirconia. And the crowns, the trying crowns are autoclavable and they are reusable. So this is how we try, prepare, and then are ready for cementation of the crown. Cementation of the crown, though I have mentioned glass ionomer, glass ionomer has a lot of disadvantages when it comes to the cementation for zirconia. The biggest, we don't choose glass ionomer, rather choose glass ionomer only when you have a patient who is not going to be cooperative enough for you to isolate for a resin cement. Resin cements and RMGIC are our best available choices for zirconia. So I have included some of the literature which is available for cementation of monolithic zirconia. Most of them, the best that they say is either your RMGIC or your relic. So looking on further at the advantages that zirconia crowns per se have, one is high-end aesthetic, next is superior durability and ease of placement compared to composite restorations or strip crowns except for the. So the disadvantages include significantly more time which is required for tooth preparation, and so because the crown has to passively fit, bleeding from the gums because the margin is subgingival, and adjusting the crown is very difficult or almost impossible. So it may these are some of the disadvantages along with inflammation which may hinder with setting of the cement, right? So let us move on to what is the clinical success which is being shown with zirconia crown. This is one of articles from India where the crowns were followed up for 36 months, for 3 years, and they have shown that zirconia is a viable, good material which crowns are provide parental satisfaction and good biocompatibility. Some of the other systematic reviews, one of this which I have already said, the Elzan Bagdi article from 2022. That's a wonderful article, please to go through it. There are also comparisons between zirconia and reformed metal crowns or our stainless steel crowns. So to quickly recap, till now we have looked at what are the classification of aesthetic crown, what is zirconia crown, the composition of zirconia crown, what makes them unique. We've also looked at tooth preparation for zirconia crowns, some of the other company crowns which are available, and also the advantages, disadvantages, and clinical success of zirconia crowns. Now we will move on to other aesthetic crowns which are available. There are a wide range of aesthetic crowns which are available. I am just going to go through a few of those, about 3 or 4 of those crowns which I look in detail. Crowns are crowns which are made from composite resin material. They're very similar to our strip crowns or our pedo jacket crowns, which we'll be talking about next, and they can be finished with a high-speed finishing curve. They are very brittle and they are more expensive than the other forms, and they cannot be crimped. That's something that we all know. Then pedo jacket crowns, basically they are tooth-covered polyester materials, very similar to our strip crowns, but the thing is that we can leave them on the teeth after polymerization, unlike our strip crowns. They can be trimmed with scissors, but you cannot use a burr to adjust them. That is their disadvantage. Then one big advantage or indication is they have a very same interproximal wall. So you can use it whenever you are having adjacent respiration, minimum amount of tooth reduction. Another disadvantage is, since it is not like a strip crown where you can pick the material of choice, there is only one shade which is available. The other crown which is available is your art glass crown, which is basically a polymer crown which provides a very natural feel, and it can be bonded with composites. It has good aesthetics. It has about 75% filler, which is microglass and silica filler, which are available. They are available in 6 sizes for primary teeth, but they have only one single shade. They have good durability in aesthetics when you compare it with strip crowns, but definitely they have more longevity also, because they can almost be covered compared to our zirconia or porcelains. So the next crown is the PediaRare crown, which are basically metal crowns very similar to our stainless steel crown, but instead of stainless steel, the material which is used is aluminum. The advantage of using aluminum, the aluminum has a epoxy coating, which is this coating is more adherent to aluminum than the stainless steel crowns. So these crowns are easy to cut, and they can be crimped well, and usually do not cause any chipping of the epoxy coating which is there. And it is available in universal sizes which can be adapted for either side or either for side of the arch, right? But they are relatively less durable. Studies have shown, which we are looking at, they are less. So the next crown that we are going to be looking at is the Figaro crowns. These are white, metal-free, and they are also bisphenol-free crowns. They are basically made from composite resin material in which there are embedments or filaments of quartz or fiberglass. Basically the same as what we use for the fiber pores in endodontics. So they flex fit. So the crowns have a good adaptation. They can also be trimmed or crimped. And one big advantage of the Figaro crowns is that they claim that the tooth reduction is, they're shown to have lesser tooth reduction required than the zirconia crown. The tooth preparation is very similar to that of the stainless steel crowns. Edelweiss crowns are basically laser sintered polymer, pre-polymerized crowns. They are the shells which are made of hybrid composite. They are radio opaque, and basically the opposite tooth wear is very less with these crowns. The last crown we will look. So the last in these series of crowns is the Bioflex crown, which is a made from a high-strength hybrid resin polymer material. Kind of combines both the features of the zirconia and these stainless steel crowns. It's got a very flat occlusal surface and uniform axial thickness, and they are pretty flexible. So we will also look at, since we are at the topic of crowns, before we move on to comparing and looking at the clinical success of these crowns, let's also discuss a group of crowns which are called as the biologic crowns. Basically, these are from a technique which is first described by Chesak and Edelman, where the tooth fragment is of a natural tooth is rooted in as a crown. So it is a biological method of restoration. So usually you can either select the tooth from a tooth bank, or if it is the patient's own autogenous also we can use, right? But it has to be saved right. So biological crowns have been used before. Technique I think is quite explanatory by itself, and there are good studies which are there on this, but most of them are case reports which are there, and they are usually they are as a part of space maintainers, but there have been one or two ways where it has been used as a crown. So now we'll start summarizing based on different studies. So we'll compare the different crowns which are available. That is your kinder, these are zirconia crowns which are available. So we will compare them how they are. So we know that kinder crowns, there are 2 shades, and their properties, basically they have the incisor lock. Let's not forget that. This helps them to for better retention. Now there is no recommendation that they have given, no work that they have recommended. And they have recommended for a 1 millimeter overall reduction both in the incisor, interproximal and facial surfaces. Cementation, the company recommends for a pure glass ionomer cement for cementation. The new smile crowns, the posterior primary molar crowns, they have both a narrow and a regular width. The one other thing that we have to remember when it comes to our smile crowns is they have a tri-in crown of which is pink in color. So remember that, that may be useful information for your viva. So they have, the veneer has an equal thickness and the cusps are a little less prominent, but still there is quite some there which has been seen from these crowns. When it comes to tooth preparation, there needs to be a overall reduction of almost up to about 1.5 to 2 meters on all surfaces, and preferred to cement them with resin cements or resin modified cements. For a Shen crown, 2 to 7 sizes, and usually we use size 2 to 3 for pediatric. Single color, they have a right and left contour, and they have regenerative margins in them which are crimped. Okay, and the reduction is about 1 to 2 millimeters, and the subgingival interproximal cuts are also required. Basically, there are counts which are there for molar and for the cuspids, and they have both small, large, and mid-sized crowns for both these. They have very thin incisal edges which might cause a little chipping. They are minimally tapered walls, and basically they have their own burrs which are available. Reduction, again, like zirconia, it's almost about 1.25 to 1 meter plus more. And resin cements are supposed to be used for cementation of these crowns. We will also look at a very broad comparison between stainless steel crowns, zirconia crowns, and resin-based composite crowns. This slide can also help you to look at what are the different properties that you can choose to write about when you're writing an answer on crowns or when you're preparing it. So when we look at aesthetic appeal, we all know that zirconia crowns have the most excellent appeal. Probably resin-based composite crowns like strip crowns are also almost there. Durability-wise, zirconia crowns have shown as good durability as that of stainless steel crowns. The most cost effectiveness can be seen with stainless steel crowns and resin-based crowns. Zirconia are a little more expensive than stainless steel crowns. When we look at caries prevention, stainless steel crowns have been superior, and look at hypersensitivity. As of now, zirconia crowns have there seems to be no case reports of any hypersensitivity because of zirconia crowns, whereas we are aware of the medical allergy which could happen with the uniform stainless steel crowns which are available. First stage of discomfort has been stated for both stainless steel crowns and some zirconia crowns if the tooth preparation is very extensive, but it is more for the stainless steel crowns. Gingival health is moderate in stainless steel crowns, whereas zirconia crowns have shown superior gingival health. Gingival health with resin-based strip crowns are not up to the mark, especially in a long-term follow-up. Clinical indications, all these three are basically indicated for teeth where there are serious defects in pulpily treated teeth. But of course, we can use a stainless steel crown in a tooth with bruxism, which we may not be able to. We already looked at certain situations where we cannot use strip crowns or zirconia crowns. The tooth reduction, that is one major disadvantage of the zirconia crown. We said that almost more than 2 millimeters of reduction, or 1.75 to 2 millimeters of overall reduction is required for the zirconia crowns, which is much more than what is required for the stainless steel crowns. Parental satisfaction is the highest with the zirconia crowns, also strip crowns, whereas there is moderate reported parental satisfaction with the stainless steel crowns. Long-term stability, both zirconia and stainless steel crowns are shown to perform very well with strip crowns having very low performance over a long period of time. Especially color change has been noted, and in fact they are prone to fracture. The plaque accumulation is moderate with stainless steel crowns, a little more with resin crowns, and it is in zirconia it is much less. So this would help you to summarize between stainless steel crowns, zirconia, and resin-based strip crowns. So far, we have looked at a very comprehensive look at some of the features and different crowns which are available in the market now. Now, let's look at some inpediatric crown from our exam point of view. So, what are some of the questions which have been asked before? Strip crowns have been asked multiple times. Zirconia crowns have started finding their ways to the question paper, and any of the other crowns could be asked, like pre-veneered crowns could be asked as a short essay. Comparisons between stainless steel crown and zirconia crowns have been asked, and anterior aesthetic crown updates can be a recent advances paper by itself. Or aesthetics in pediatric dentistry can also, this aesthetic crowns can become a huge part of the answer on improved aesthetics in pediatric patients in case it is a recent advanced paper. Remember, whenever you are answering a question for each one of the crowns, start with the introduction, know the composition of each one of these crowns, their properties, where are they specifically indicated, what are the absolute contraindications, if any, and specific contraindications, what is the preparation armamentarium for each type of crown, the cementation, what is the cement that you use, the advantages and disadvantages of each one of these crowns, their clinical success or longevity. Also remember to read at least one or two references for each one of these crown types. So to summarize, I'd like to say that a PT exam is not a test of your memory, but an evaluation of your ability to build and present a scientific argument. There may be many references in terms of aesthetic crowns, like we've seen, there may be a lot of it. So you will have to develop an understanding of all these different crowns and be able to present well in your exam and build a good argument regarding any one of these crowns if it is an exam paper for you. Let me take this opportunity to thank the Society of Pediatric and Regenerative Dentistry, the head office, and members from the organizing team led by Madhu sir. Thank you so much for the opportunity. Thankful, grateful, and blessed to be part of this. As always, I'd like to end by saying let us not stop at shaping smile. Let us shape some lives too in whatever small ways that we can. All the very best to all the postgraduates who are appearing to the exam now.
I think most of the questions I have answered. Some which whatever I have not answered, it is because I do not know the answer to give you offhand. I'll definitely find out and give you a clear answer. I have shared all the PDFs and and a PDF of the PPT also in the chat box, so you can download it. I've put together all the systematic reviews together as a single PDF on different topics. It is there as a PDF, so you can take it down.
Thank you, ma'am. Thank you so much. I would like Mr. Dev to present the certificate of appreciation to Dr. Subbalekshmi, ma'am. Students, please note, ma'am has uploaded the reference articles in the chat box. Please do download it before signing out. The presentations will be uploaded on the website as soon as possible. You can download it and watch it whenever you require it. So that's the end of the second session for the day. I would like to thank all the speakers and Pandit sir and Dr. Nagarathna ma'am for moderating the session. I would kindly request Mr. Dave to present the certificate of appreciation to Pandit sir and Dr. Nagarathna ma'am. Thank you so much, sir. Thank you so much, ma'am.
Thank you very much. It was wonderful.
Thank you.
Having
Thank
heard
you for
all
this
these
wonderful.
expert speakers for this, and I am sure that there has to be a little more modification, because this time we are having this sort of preparing students for examinations. So all I think this presentation should be oriented that way: how exams are being conducted, how questions are coming, and how students should be prepared to answer in an exhaustive way. And that there is a difference between when we are speaking and the conferences where you put in your own research and your own thoughts. Here the difference is that we all should maximize our energy into pumping so much of work in the subject wise which they are going for examinations. So they should be ready reckoner with them so that they can easily go through and make notes out of it, and they can pass examination for the better rank, and then later on they might use it in their clinical practice. I'm thankful to ISPPD head office for visualizing this and making it. I think we are the first people to start this preparations for our postgraduate, which is the backbone of our society, for their forthcoming examinations. Besides having regular conferences, PG seminars, PG programs going on throughout the year. So ISPPD head office, Dr. Venugopalan and President sir, they are working very hard for making this available to our students and our faculty. Thank you.
It's wonderful for all of us to be here in this learning platform. I thank ISPPD organizing team for giving this wonderful opportunity. I also think very nice to be associated and also be connected with you. Thank you very much.
But one question is that I couldn't see Dr. Nagarathna's face on this platform. I think she is all the time.
Video is not on, madam. Nagarathna, madam.
Because it is always a pleasure meeting Dr. Nagarathna.
Same here. Warm regards to you, sir.
Thank you, ma'am. Thanks everyone for joining for the session today and make it a grand success. We would request you to join tomorrow.
It was a very informative session. It was again, working hard.
I think the voice is breaking now.
Make it
I think ma'am has a network issue.
No problem. So let us finish it today's session. We'll meet again tomorrow.
Thank you, sir. Thanks, everyone. Students, please note the articles will be uploaded on the website shortly. I saw many of them complaining that it's not available. Whatever ma'am has shared, we'll be uploading it on the website too. Thank you. Thank you so much. See you soon tomorrow. Please join 15 minutes early. Please be there by 9:15. We'll start the session at sharp 9:30. Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you. Subbalekshmi.
Thank you, Dr. Madhu.
Yeah, ma'am. Thank you.
you all. Thank you, sir.
Thank you, Dr.
Thank you.
Indira.
Thank you, sir. Thank you, sir. Thank you so much. Afternoon, sir. IK Pandit, sir.
I just missed your
Yes, sir.
lecture, but yeah,
How are you, sir?
all well. Everybody is doing well.
Ma'am, your presentation was good.
Thank you, ma'am. Good afternoon, sir.
Okay, sir.
Good
Bye.
afternoon, ma'am. Application here.